Hi everybody, thank you for joining us today. I'm Naomi. I am part of the clinical team from Hartman. My background is community nursing predominantly, but I have worked both acute and community nursing as a staff nurse and then as a TVN for York and Leeds Trust. But I've joined the Hartman team, joined them early in the year, and now part of the clinical team, and we do a lot of education and supporting you guys out there in practice. So here today to talk to you about the fundamentals of wound healing, but just before I go any further, I just want to get an idea of who's in the audience. I know I have seen a couple of you at the stand, but who have we got? So obviously this is a general community nursing event, so we've got community nurses and district nurses in the room. Just pop your hand up. Yeah, lovely. We've got any practice nurses? Yeah, nice to see you. Acute, anyone from acute? The acute setting? Oh, great, nice little mix. Anyone from hospice or anything like that? Lovely. Nursing homes, care homes? Brilliant. We've got a good mix. Student nurses? Anybody students? Good, nice to see you. Any other healthcare professionals like physios and OTs? Rehab?
OT background.
OT, lovely. Yeah, nice little mix. Anybody I've forgotten?
Retired.
Retired. And just interested.
Yeah, keeping my hands in.
No, that's great. That's good to see. Yeah, nice to see a good mix. So, like I say, my background is predominantly community, but a bit of both. So hopefully, we can pass on some experience. So we're going to look at the 12 activities of daily living and how these can be impacted when we've got a wound, and we're going to talk a little bit about shared care and how we can support patients with their shared care as well. Now, for those of you that are trying to rack your brains and remember what the 12 activities of daily living are, trying to go back to your student nurse days, I know when I saw the reference of Roper, Logan and Tierney, it gave me a little bit of fear of remembering of that first assignment I had to do as a student nurse. But we are going to go through each one in turn and just look at how each one is impacted when we've got a wound. But before, this always throws me, this slide. The first one we're going to look at is eating and drinking and thinking about nutrition. So nutrition is the taking on of food and fluids, and we use that for growth, metabolism and repair. And obviously repair is the big thing we're trying to do with wound healing. But we know that a lot of patients out there are malnourished. So can you just shout out some reasons why we think that our patients or patients out there in the community might be malnourished? What's going?
Poverty.
Yeah.
Knowledge.
Yeah. Yeah. What was that, sorry? Depression, was that? Yeah. And what else? When we're thinking about wound care, what else might affect them being able to get nutrition?
They have limited access to their facilities. It's not appropriately adapted.
Yeah. So that maybe their mobility and things like that. Yeah, brilliant. So, like I said, nutrition, the taking on of food and fluids that we use for metabolism and growth and repair. And malnutrition, like I said, does affect a lot of our patients. We have an elderly population, a lot more comorbidities and things like that. We know as we get older, where our metabolism decreases, might be less active, we might not be building up that appetite and things like that if we're not doing as much. But also our physical ability to go and get food and fluids. So that might be, they might have a neurological disorder, they might have had a stroke, they might have had a limb amputation, or their wound might be stopping them from mobilising as well. And therefore they might not be able to physically go and get their food and fluids from the kitchen, might not be able to feed themselves, but equally might not be able to go out and shop for themselves. And I think that's a big factor in taking on nutrition. I know for myself, I do live on my own, but I absolutely despise shopping, any form of shopping, whether it's clothes shopping or food shopping. But even though I really hate food shopping, I still do not like doing online shopping because I don't like somebody else picking my food for me. And when you're walking around the supermarket, you might see something you've not had in a while, see something that just might take your fancy. So you can really see how patients that are not going and picking their own food might end up eating the same thing, and it just gets a little bit boring, and then they don't want to eat, and it just takes that interest away from food. And food does have to keep interesting, and it's a social thing as well, like going out for food. So if you've got a wound and you don't want to go out, or if you don't want people to come round, you're not having that social aspect of eating with somebody as well. And then when we're thinking about wounds and we're thinking about nutrition, think about what we're losing in wound exudate. So wound exudate is we're not only losing fluid, but we're losing protein as well, because we know that protein's present in wound exudate, which leads us nicely onto this slide. So this is looking at our requirements, so our daily requirements, but also how much additional requirements we have when we have a wound. So our protein requirements written up there. So our protein requirement can double when we have a wound, but then double again if we have a highly exuding wound. And how many highly exuding wounds do you see out there? Probably quite a few. You know, those really wet legs, those really large open abdomens, or those pressure ulcers that are leaking a lot. Now, I did a quick calculation on myself. I was maybe a little bit generous and knocked a few pounds off. We're coming up to Christmas. But if I had a highly exuding wound, I would need 195 grams of protein, so nearly 200 grams of protein. Now, just to put that into context, for an extra 40 grams of protein, you would need to consume 2 pints of milk, or 6.5 eggs, or a 200 gram rump steak. Now, I don't know any care facility that's providing rump steak. If you do know of any, I will go there. But you can really see how much extra our patients need to heal wounds, and also how difficult that is to get in. Because I know a lot of patients out there, I think even getting an extra egg in them a day is difficult, let alone getting an extra 6 eggs in them a day. And protein is essential to wound healing. Protein is the building blocks of all new cells, all new tissue. So if we're not getting enough protein, we're just really going to be at risk of delayed wound healing. Carbohydrates. So carbohydrates are broken down into glucose, which we use for energy. Energy is needed for everything. We're all using energy. Just sat there listening to this, we're using energy. So we need extra energy to heal wounds, sorry. But what's actually quite interesting is if we're not taking on enough carbohydrates, so we're not making enough glucose, what your body starts to do is to break down protein to create glucose to use for energy. So you can see if we're not getting enough carbohydrates, we're then going to be depleted on protein as well. Then moving on to fluid requirements, we all know how important fluid is. We wouldn't last very long if we didn't drink. But fluid is really important to wound healing. Moist wound healing environment is essential. There will be a few people in the room that hate the word moist. I know there will. But moisture is essential to wound healing. Exudate is essential to wound healing. In the right proportion and in the right places, you know, we need exudate because exudate is required to move cells across that wound bed to help deliver nutrients across that wound bed. And for final wound closure, so your epithelial cells move across that wound bed with wound exudate, finds that edge of that wound bed and closes in, and that's how your wounds heal. So if the wound's too dry, if we're not taking on enough fluids, then we're going to have risk of delayed wound healing. Was that all I was going to say next year? I think so. My mind's gone blank. Moving on to micronutrients. So you could have a whole lecture on nutrition and on micronutrients and where to find them and things like that. But really thinking about the 5 a day, really thinking about having a colourful plate, having all the different food groups on that plate as well. But just to pick out some key nutrients, so vitamin A, C and E are really key for antioxidants and for that immune response. Vitamin K, essential for blood clotting, and that's your first phase of wound healing. And then iron is essential for delivery of oxygen to the tissues and therefore delivery of oxygen to your wound bed. So they're just some really key ones. Like I say, you could be here all day looking at all the different vitamins and minerals out there, but really essential, we have a colourful plate and we're offering a variety of the different food groups as well. So that's just to summarise. So with a chronic wound, increase the protein requirement is increased by 250% and your calorie requirement could increase by 50%. So just really something to think about with nutrition. I think nutrition is often one that's quite often overlooked. We don't often think about it enough. But do refer on to your dietitians as well, because like I say, I gave examples of how much extra protein we need to take on. And I know that is difficult with a lot of our patients, so do refer to your dietitians and do utilise your multidisciplinary team. So moving on to elimination, washing and dressing. Now, does everybody recognise that type of wound that we've got up there? Yeah, what's that showing? Moisture, yeah. So your moisture-associated skin damage. So moisture-associated skin damage refers to skin damage to any area exposed to excessive moisture. So that could be moisture to poorly managed exudate, it could be moisture due to sweat, we can get that in skin folds. But obviously here we're dealing with moisture associated with incontinence. Now, the first thing I want to say about incontinence is not to assume, we shouldn't just accept that people are incontinent. Just because they're elderly, just because they're in care, just because they're in a hospital setting or whatever, we shouldn't just accept they are incontinent. You know, we should be trying to look at ways how we can make patients continent. You know, thinking about, is it because they haven't got easy access to the toilet? Is it too far for them to walk? Has their mobility recently decreased because of their wound or because of some surgery or something else that's gone on, and therefore they're not able to get to the toilet quick enough? So do we need to position them closer to the toilet or help them a little bit more? Do we just need to offer them to go to the toilet a little bit more? Some patients with maybe cognitive issues or maybe dementia or something, they may not have that muscle, that trigger that tells them they need the toilet. So they might need to be sat on the toilet for that muscle memory to think, okay, I'm sat on the toilet and I go for a wee now. So that might help them be a little bit more continent. And then also they're thinking about their dexterity. So are they able to undo their buckles and belts and zips? Do we just need elasticated pants? Would that help them be a bit more continent? So just really think about, you know, these different elements before we just assume they're incontinent and just pop a pad on them. And then coming on to pads, so pads should be selected for the correct size and absorbency, okay? Thinking about the absorbency we need. If we need help with that, do utilise, like if you've got a continence team. When I was a TVN, I worked a lot alongside a continence team. I did a project in York with them, and they are brilliant. They're brilliant at what they do, and they're a really good resource, so do utilise them. And I'm going to try and pass on some of the things they mentioned to me on these slides as well. So if we're using continence pads, we need to make sure that those continence pads are in direct contact with that skin, because what we want to do is as soon as urine hits that pad, we want it to be taken away from that skin to help reduce this risk of moisture-associated skin damage. So we need to be using pads and fitted pants. Okay, nappies generally are ineffective, and we certainly shouldn't be lying patients on pads in a bed, because that's not going to take away that urine as soon as it hits there, because we've got all that area between the groins that what moisture is likely to sit there and likely to cause an issue. So we need to have pad and fitted pants on. Thinking about looking after the skin. So when we're cleansing the skin, it needs to be, we say it needs to be a pH balanced cleanser. So that's just plain water, so nothing with perfume or alcohol in that's going to damage that skin further. So just using plain water. But if we've got quite severe moisture associated skin damage, there are some of those foam cleansers out there that, you know, there's different products. So I can't really, you know, obviously it depends what's on your formula, it depends what's on your pathways and things like that, but there are specific foam cleansers out there, but they're generally for severe moisture associated skin damage. So it's remembering to step up and step back down to get the best out of these products and to make sure that we're utilising them appropriately. Because as well, if we overuse these products, they can dry out the skin. If we're not using them in the correct way and on the correct sort of like moisture associated skin types, then they can dry out. So neutral skin cleansers that are not going to cause further damage to that skin. And then skin protection, so your barrier products. So really important that we use a barrier product to protect that intact skin and trying to retain what good skin we have there. But if we are using barrier products, just remember if we're using the creams or the ointments, once we've applied them on the buttocks, not to wipe our hands on the pads, because that's going to stop the pads being as effective. And we've all done it, because I've done it, and it wasn't until the continence team told me. Because if you think about it, you've got the barrier products are designed to not let moisture in, so if you're wiping that on the pads, it's going to stop them being as effective. And then thinking about washing and dressing if they're going down to the lower limbs. So who are the skin pickers out there? There's bound to be a few, because I definitely am. Yeah, loves a good skin pick. Yeah, definitely. Keep doing that. So when we've got lower limbs and they're in bandages a lot, it can get really dried out skin. So we need to be really giving them a really good wash and a really good moisturise as well. The reason why we like to get rid of those thick, dry skin plaques, obviously only take off the ones that easily come off. We don't want to cause any more wounds. But if we're not taking those thick, dry skin plaques off, the posh word is hyperkeratosis, if we're not taking them off, bacteria can harbour under them. And also, if we're allowing that skin to dry out, potential to crack and potential for further wounds to occur, which we don't want, do we? So that's that for that one. Controlling temperature. So, we know that there's an optimum temperature that we function best at, and it's similar for wound healing. So, we need to maintain that optimum wound temperature, body temperature for wound healing. If we're doing, for example, unnecessary dressing changes, so if we're taking that dressing off daily unnecessarily, And we're not only disturbing wound healing, but we're potentially decreasing the temperature of that wound and potentially delaying that wound healing. So generally we say, change dressings as wound exudate indicates. And then on the other end of the scale, thinking about elevated skin temperatures. So if you've got somebody that can't control their their temperature very well, or someone that might have an infection, so is a little bit clammy and a little bit sweaty, that can increase friction and then therefore can put them at for higher risk of pressure ulcer formation. So just worth something thinking about. The next one, mobility and maintaining a safe environment. So, we all know immobile patients are at greater risk of pressure ulcers. We could have all the equipment in place in the world, but if we're not repositioning them, if they're not mobilising or getting repositioned effectively, they are still going to get a pressure ulcer. So mobility is really key in prevention and management of pressure ulcers. Similarly with skin tears, so if our patient isn't as mobile and they're relying on us to help with moving and handling, to help mobilise, we might be putting in slings, we might be physically turning them, they are at higher risk of skin tears. So really ensuring we're sticking to uniform policies, short nails, no rings with large stones, things like that, really reducing the risk of causing skin tears to our patients, because we are seeing a real issue with skin tears not healing properly and really becoming chronic wounds as well. And then thinking about mobility, thinking about, we have got a risk of slower healing rates with lower limb wounds if they're not as mobile. So if they're not mobilising, they're not activating that calf pump, and that calf pump is what helps with venous return. Then that helps reduce edema, which in turn helps to improve wound healing. And then sticking with lower leg wounds, so think about what we're using to dress it with. So if we're putting bandages on, making sure they're not too bulky and they can put their footwear on, so reducing the risk of falls. If we are using bandages, you're making sure they're not going to unravel, so making sure they're secure, or that, if thinking about the types of patients we might not put bandages on, because if that patient's going to pick at that bandage, again, if they've not got the cognition to remember why they've got that bandage in place, they might think, I want to take this off, take it off, unravel it, at risk of falls as well. Sticking with lower limb wounds, just making sure we're managing that exudate as well. So we're making sure that we're using the appropriate absorbency dressing. So again, that we're using a highly absorbent dressing if it's a lower leg wound that's leaking a lot. And then thinking about using a backed dressing as well, so preventing that strike through coming through to outer bandages. Because if we are getting strike through and the footwear gets wet, again, that could be a falls risk. One thing to take into account that we sometimes don't think about is this patient at risk of self-harm? And if so, could this dressing be used to self-harm? So for example, bandages can be used as ligatures, and I'm sure I can see some nods, so I'm sure some people have maybe come across that, or, I hope you haven't experienced that, but, we've heard about that. Also, can they access their wound to self-harm? Do we have to think about how we dress it? Because if they're going to access that wound to self-harm. And one really unusual question I got asked when doing this job was, what if my patient ate your dressing? What would happen? What's the risk? So again, just something you might have to think about, depending which sector you work in, just think about self-harm. Work, play and communication, something I think we all took for granted until the pandemic hit. I know most of us would have probably worked throughout the pandemic, but still, when it came to those social situations, you weren't able to get out, you weren't able to see your family, you weren't able to do your normal things. You can realise how isolating it is. But that's a reality for a lot of our patients. Day in, day out, they are really quite isolated. And that might be through choice or it might not be, But that quite often it's because of the embarrassment. I know if you talk to a lot of patients, that embarrassment of the malodour, the embarrassment of that strike through, of leaking everywhere if they've got particularly the wet lower legs and things like that. So really can be quite isolated. So, if we really try and work with our patients and get on top of these issues, try and help them get out. We know it helps with their stimulation, it helps with their mental health and everything. And I'm sure some of you, again, have heard patients, I've certainly heard patients, I've been to their houses and said, I don't even want the family to come round because I feel like the house stinks, I feel like I stink, there's exudate everywhere. That must be really quite isolating to not even want your own family to come round. And how many of you here has knelt in wound exudate when you've gone to do those wound dressings in somebody's house? Yeah? Yeah, and how did that feel? Horrible, isn't it? Horrible. The wound exudate stinks, your uniform's wet, and it feels horrible. But again, that's the reality for a lot of your patients, 24/7. So just something to really think about. And then also, you know, we do talk a lot about our patients being elderly, but there might not be, you know, this might be young patients that have a wound, and it might affect their financial status, it might affect their ability to go to work. So just something else to think about. Breathing. So there's two ways in which we can think about breathing. How it affects wounds. So if we've got a chronic respiratory condition, that can affect the perfusion to, you know, to our wounds. So if we're, you know, we've got one of those really chronic respiratory conditions, but also can affect our mobility. And we already spoke earlier how mobility can affect, you know, obviously risk of pressure ulceration, delayed wound healing with lower limbs. You know, some of these patients really do struggle when they've got these chronic respiratory conditions. My first job as a healthcare assistant was on a respiratory ward, and I do think these are some of the sickest patients. You know, I remember having a patient who could barely even take a mouthful of food without then having to reach for their oxygen mask. So again, you can see how that affects their nutrition, which then affects their wound healing. Sleeping. So again, sleeping, something we all take for granted until we can't sleep. And then we feel dreadful. So for everybody, I'm sure most of us in the room have done night shifts. We all know how dreadful we feel. Messes up with your, you know, your food intake and everything, doesn't it? So again, you can see how that impacts on a wound, and also their psychological state. You know, I am a horrible person if I've not had enough sleep. Don't talk to me. I don't want to know. And then, you know, if your patient hasn't had enough sleep, and then you're trying to talk to them about the importance of getting in compression, and you know, oh come on, we need to get into this, and they just don't want to know. So yeah, sleep, it is a difficult one. But yeah, trying to get on top of that pain and trying to drill down where they sleep and why they sleep in a certain place. So if they're sleeping in the chair, that could put them at higher risk of pressure ulcers because they're not going to bed and they're not distributing their pressure, you know, like laying down. But equally asking why they sleep in the chair. Is it because they can't physically get into bed, or is it because it's too painful to get into bed? If they're saying that it's too painful to rest their legs up at night, that could be an indicator that there's some arterial disease going on. So that might then indicate a further referral to vascular services. So it's always worth questioning your patients about their sleep. If they're not getting enough sleep, can delay wound healing because lack of sleep can interfere with, I need to read this because I always forget this bit, with your immune system, and it does reduce production of collagen, which is really important in wound healing. So yeah, always worth to tackle the issue of sleeping. Final one in the activities of daily living is diet and expressing sexuality. Something we probably don't think about until, you know, having those dying conversations, something that, you know, we don't think about until it's present, until it's there. But when we're dealing with wounds in end of life care, you know, we're often probably not thinking about wound healing, we're probably thinking about wound management. So particularly if we've got wounds like fungating wounds, have we all seen the fungating like breast wounds, and you can get them in real intimate areas like fungating anal wounds as well. I have seen a few of them as a TVN. So not only the intimate areas, you know, it can be really quite painful, really quite sore. So with those wounds, we're probably thinking, like I said, about wound management, managing malodor, managing exudate. If we can manage those symptoms, you know, we might be able to help those patients be intimate towards the end of their life. And, you know, with intimacy, we're not always talking about sex. It might just be a little cuddle with their loved one, you know, brother, mother, son, friend, whoever. You know, if they could have a cuddle towards the end of their life, I'm sure that would mean a lot to them. So I was worth thinking about that and thinking about like the whole quality of life element. So for the last little bit, we're going to talk about shared care, and, you know, just thinking about how we can maybe bring this into practice a little bit. So it's probably something you might have heard, been bandied about out there, and it's something I think we're trying to push towards because we know that our resources are limited. So shared care. So it's the patient and healthcare professional working together towards a shared goal. So that's one thing, it's a shared goal. You know, both sitting down agreeing together, what's your ultimate goal? Because what you think might be bothering the patient might actually not. It might be something totally different that's bothering the patient. And ultimately, obviously, what we always want to do is we always want to heal our wounds. That'd be great if we could heal every wound, but, you know, and that should hopefully always be our ultimate aim. But what we might need to do is just do smaller goals to help achieve that aim. So some of those things is maybe just getting your patient on board. You know, if we can get our patient on board, it might help them get engaged a little bit better, taking on some responsibility as well. I think what patients struggle with wounds is they feel like they're out of control. You know, they've got no control over their wounds. But also, it's about, like I said, taking a little bit of responsibility, because particularly with wound care, I think we do almost take on too much responsibility. You know, as a TVN, I used to go in and people would be like, oh, TVN's here, she's going to heal your wound. I was like, oh, okay, a little bit of pressure. But also, it's not up to me to heal the wound. It's not my wound. It's that patient's wound. You know, they need to do things. Yes, we're there to support them, and we're there to, you know, to support them with that journey. But, you know, it's up to them as well. So maybe if they can help with a little bit of nutrition, if they've got a highly exuding wound, asking them to drink a little bit more, and explaining why, you know, you're losing this fluid and you're losing protein and things like that. With their hygiene, can they wash their leg or wash themselves before you come round or before they come see you? Getting them involved that way, or moisturising them still, helping them to put some emollient on, you know, and explaining why it's really important to get these things, and helping to promote a little bit of independence as well, you know, giving them that little bit of responsibility back. So this is, you know, and it's all thinking about this holistic approach. And again, I think we talk about doing this holistic approach quite a lot, but for those of you that have been to the stand, you might have seen, or you might have picked up a wound balance leaflet. If you haven't, then do go to the Hartman stand, because we have produced this white paper, and it is available. There is you can find where you can find the white paper available on here. But the wound balance is basically, it's kind of a concept of looking at how we can achieve wound balance and achieve wound healing with these patients. So there's 3 elements to the wound balance paper. So it's looking at that wound. So how can we get balance back to that wound? Because we know with chronic wounds, there's a lot of cells present, so a lot of cells that are really important to wound healing. But actually, when those cells are out of balance, when there's too much of a certain type of cell on that wound bed, it puts it into a chronic non-healing wound state. And what we need to do is we need to pop that back into an acute healing state. And one way we can do this is by using like a superabsorbent polymer dressing, because what these do is these absorb the exudate into the core of the dressing, and they just help to rebalance some of the cells on that wound bed. There's also the patient care element. Now, the patient care element is all to do with quality of life. There is a quality of life questionnaire referenced in this paper, so you can have a look at. And that just helps to prompt maybe some conversations with your patient. You know, like I said, what is it that's bothering you? What is it that's bothering your patient? Because it might be something totally different to what you think. And equally, if we can measure these quality of life elements, if we can measure it and maybe show to your patient, look, you said last week that your pain was an 8 and now we've got it maybe to a 6 or something. Even those little bits might just help get your patient bought into this journey with you. And then there's the clinical care element. So this element is thinking about using our resources effectively, keeping ourselves up to date. So you're all here today getting some education, so that's great. You know, you're helping to provide evidence-based practice. That's what we all need to be aiming for. Evidence-based practice, consistency in practice, you know, all singing from that same hymn sheet. Just lost my train of thought then. And all just using our resources effectively. And one way we can use resource effectively is by this shared care. You know, if we can get people doing a little bit of care themselves, it might free up some of your time. I'm not making promises, but it just might do. So just to finish off, just got a couple of case studies to look at, and just an example of how shared care can help to put people on this healing trajectory. So this first case study, 70-year-old gentleman, type 2 diabetes, diabetic foot ulcer on the side of his foot, was initially assessed 4.4 centimetres squared, 50% slough, 50% cranulation, and we weren't sure how long this wound was present. So likely a chronic wound, because if the patient wasn't sure how long it was present, we're talking a few weeks, so chronic wound. So this was dressed in clinic every 6 days, and the patient self-managed in between. So it was dressed with a superabsorbent polymer dressing to help rebalance those cells on that wound bed. Offloading was prescribed, so advised to offload, really essential. You know, if we're not going to offload pressure, likely not to heal a wound. And then the patient did self-manage in between, and you can see by day 12 it had gone to 100% granulation and the wound area had reduced by 60%. Now the point here is that the patient self-managed in between, and there was healing seen. So, you know, quite often we might write patients off too soon because we think they can't manage, or we think, oh God, there's a risk, you know, they're not qualified, so they're not going to be able to do it as well, or there might be a risk to infection, things like that. But actually what we can see is wound healing can be achieved with shared care, so that could really help utilise your resource more effectively and free up some of your time. And equally for this one, another 73-year-old gentleman, type 2 diabetes with a diabetic foot on the foot ulcer on the outside of his foot, wound present for 9 months, so again we're talking about a real chronic wound, and 6.75 centimetres squared wound area, 80% granulation and 20% slough with maceration. So again, with that maceration present, they've used a superabsorbent polymer dressing to help manage that exudate, help rebalance that wound bed, help get those cells rebalanced. Offloading, really important to offload to, you know, help that area heal. You know, offloading helps that tissue perfusion and things like that. And equally, he self-cared, this gentleman, and you can see the wound by day 7, so a very short period of time, considering that this wound had been present for 9 months, by day 7, the wound had reduced by 20% and the granulation had increased to 90%. So again, what it's showing there is that we can't pinpoint which element helped with that. It was probably a combination of all three, a combination of, you know, appropriate dressing selection, offloading, the patient getting involved. You know, they maybe had some other education. It wasn't me that did this, so, but you know, they probably had some other education. You know, really important offloading, really important getting them involved in their care. That might have gotten more bought in, more positive about things. And again, you can see that wound healing can be achieved with, or certainly putting them onto a wound healing trajectory can be achieved with shared care. So it's always worth, don't just write patients off, you know, do have those conversations, make it as part of your assessment, try and get them involved with their care as well. So that's everything from me. So I don't think they've come in yet. I think we've finished probably a little bit earlier. So anybody got any questions, anything they want to add, any comments, anything at all? Don't worry if not, it's fine. You can have a little sneak off to the toilet if you want. But yeah, like I say, if you do want to come to the Hartman stand, I'll be there at lunchtime with my colleagues, and do pick up a leaflet on the wound balance if you're interested in that. And you can always ask me a little bit more about it if you'd like to. Is that all right? Thank you very much.